Thank you for listening to Depictions Media Radio. Welcome to Policy and Rights, the show about government policy and human rights. Welcome back to Policy and Rights here on Depictions Media Radio. I am your host, Michael Clogs, and we're going to have a press conference with the WHO in this particular episode, and along with that, okay, so there's a lot of things going on. Haiti being overrun with cholera, and in a dire health emergency, and then of course, back to Africa with Ebola, I believe in Uganda. COVID-19 isn't completely, while a lot of countries are pulling out and the pandemic is fading away, there's still things left behind. One, there's still booster shots to be looked at. There are combination of vaccines between COVID-19 and influenza to be looked at. There's still a lot of health emergencies going around, and there's also the monkeypox. And one of the huge jobs for the WHO isn't necessarily to fix the health problems of the world. It is to make governments aware of the health problems of the world and the inequities that lie within those health problems. One of their jobs is guidance into making sure that as we're all citizens of this planet Earth, that we all receive equal and equitable healthcare and treatment, meaning that these medicines that are developed in between Canada and the United States and other parts of the world get shared. That the research that is done in Cambridge gets shared in Chile, so that the doctors know what they're doing. That the healthcare workers know how to safeguard so that they don't continue to spread infection throughout a community. It is a very, very important thing that the World Health Organization does that needs to be looked at a little bit closer. As I get ready to introduce today's show with Dr. Tedros, going to be giving opening remarks on some of the things that I just mentioned, like COVID-19, the monkeypox, emergencies in Haiti with cholera, and Uganda with Ebola. So let's listen to what was said in this press conference by the health experts of the world.
Hello everybody, this is Margaret Harris in WHO Headquarters Geneva, welcoming you today, October 19, 2022, to our World Health Organization Global Press Briefing on health emergencies and other current health issues. As usual, we will start with opening remarks from our Director General, Dr. Tedros Adhanom Ghebreyesus, and I will then open the floor to questions. Our panel of technical experts will join Dr. Tedros both in the room and online to answer your questions. And in the room with Dr. Tedros, we have Dr. Michael Ryan, Executive Director, World Health Emergencies, Dr. Mariangela Shimao, our Assistant Director General for Access to Medicines and Health Products, Dr. Sylvie Brion, Director, Global Infectious Hazard Preparedness, Dr. Rosamund Lewis, our Technical Lead on Monkeypox, and Dr. Abdi Mohammed, Incident Manager for COVID-19. We have full simultaneous translation services, and I thank again our interpreters for their outstanding work. But without further ado, I will now hand over to Dr. Tedros. Dr. Tedros, you have the floor.
Thank you, Margarita. Good morning, good afternoon, and good evening. Last night, I returned from the World Health Summit in Berlin, Germany, which this year WHO co-hosted for the first time. I was very encouraged to see the level of commitment from leaders, from government, civil society, academia, and the private sector for addressing the most pressing global health challenges. There was strong support for the International Accord on Pandemic Prevention, Preparedness and Response, which countries are now negotiating. And yesterday, governments and philanthropic donors collectively committed $2.6 billion to work towards ending polio. Now to Ebola outbreak in Uganda. In total, there have now been 60 confirmed and 20 probable cases, with 44 deaths, and 25 people have recovered. We remain concerned that there may be more chains of transmission and more contacts than we know about in the affected communities. The Ministry of Health is investigating the most recent 8 cases, as initial reports indicate they were not among known contacts. In addition, 2 confirmed cases from the Mubende district sought care in the capital Kampala, increasing the risks of transmission in that city. I'm pleased to see that the government has recognized that risk. WHO and our partners are continuing to support the government of Uganda to contain the outbreak and prevent it from spreading in more regions and countries. Now to cholera. Around the world, 29 countries have reported outbreaks this year, including 13 countries that did not have outbreaks last year. Cholera is highly dangerous and can kill within a day, but it can be prevented with 2 doses of safe and effective oral vaccines. Since 2013, WHO, UNICEF, Medicine Sans Frontières, and the International Federation of the Red Cross and Red Crescent Societies have jointly managed a global stockpile of cholera vaccines to help control epidemics. However, the current wave of outbreaks is putting unprecedented pressure on the stockpile. As a result, the 4 agencies have decided to suspend the 2-dose strategy in favor of a 1-dose strategy so that more people receive some protection from limited stocks. The 1-dose strategy has proven effective in previous outbreaks, although evidence on how long protection lasts is limited. However, this is clearly less than ideal, and rationing must only be a temporary solution. In the long term, we need a plan to scale up vaccine production as part of a holistic strategy to prevent and stop cholera outbreaks. In addition, the best way to prevent cholera outbreaks is to ensure people have access to safe water and sanitation. Now to COVID-19. Last week, the Emergency Committee on COVID-19 met to discuss the global situation and the way forward. The committee's view is that COVID-19 remains a public health emergency of international concern, and I agree. The committee emphasized the need to strengthen surveillance and expand access to tests, treatments and vaccines for those most at risk, and for all countries to update their national preparedness and response plans. While the global situation has obviously improved since the pandemic began, the virus continues to change, and there remain many risks and uncertainties. This pandemic has surprised us before and very well could again. On monkeypox, the Emergency Committee will meet tomorrow to discuss the outbreak and make recommendations. The number of reported cases globally has now dropped for 8 weeks in a row, but as with COVID-19, risks and uncertainties remain, and some countries are still seeing increasing transmission. I look forward to Emergency Committee's recommendations. Finally, I'm running out of diplomatic language for the deliberate targeting of civilians in Tigray, Ethiopia. Earlier this week, the UN Secretary General Antonio Guterres said that, I quote, "The situation in Ethiopia is spiraling out of control. The social fabric is being ripped apart and civilians are paying a horrific price. Hostilities in Tigray must end now, including the immediate withdrawal and disengagement of Eritrean armed forces from Ethiopia." End of quote. The United Nations Human Rights Office has received reports of civilian casualties and destruction of civilian objects due to airstrikes and artillery strikes. Indiscriminate attacks or attacks that deliberately target civilians or civilian objects amount to war crimes. There is no other situation globally in which 6 million people have been kept under siege for almost 2 years. Banking, fuel, food, electricity, and healthcare are being used as weapons of war. Media also is not allowed, and every distraction of the civilians is done in darkness. Even people who have money are starving because they can't access their bank for 2 years. Children are dying every day from malnutrition. There are no services for tuberculosis, HIV, diabetes, hypertension, and more. Those diseases which are treatable elsewhere are now a death sentence in Tigray. Yes, I'm from Tigray, and yes, this affects me personally. I don't pretend it doesn't. Most of my relatives are in the most affected areas, more than 90% of them. But my job is to draw the world's attention to crises that threaten the health of people wherever they are. This is a health crisis for 6 million people, and the world is not paying enough attention. I urge the international community and the media to give this crisis the attention it deserves. There is a very narrow window now to prevent genocide. I repeat, there is a very narrow window now to prevent genocide in Tigray. Margaret, back to you.
Thank you very much, Dr. Tedros. Now, before I open the floor to questions, we'll also have some remarks from Professor Didier Houssin, who's the chair of the International Health Regulations Emergency Committee on COVID-19, and he'll expand on those recommendations that they just made to the Director General. Over to you, Professor Houssin.
Thank you very much, Madam, and thank you, Dr. Tedros, for having mentioned the work of the Emergency Committee members for COVID-19. First, I want to thank the members of this committee for their continuing work during these 3 years. I just would like to say a few words about the core of the discussions which occurred during this session. For the new virus, it clearly is continuing to circulate. But for the first time in nearly 3 years, because the number of deaths is less than some months ago, and because immunity of the human population has improved, members of the committee have discussed for the first time the question of termination of the public health emergency of international concern. But to conclude, as Dr. Tedros just said it, that unanimously that it is too early to terminate the public health emergency of international concern. There are still too many deaths. There are still too much uncertainty regarding the variant, their pathogenic effect, the immune escape effect, and there is still too much fear that termination of the fake might aggravate existing inequalities in access to vaccine or therapeutics and might demobilize all the efforts engaged to prepare for a future pandemic. So the committee concluded collectively that's the recommendation to terminate the fake, perhaps in the future, requires preliminary steps. First, a winter test in the Northern Hemisphere, and second, analyzing and preventing the negative consequences which might result from the termination of effect. For example, on the legal point of view regarding vaccines and therapeutics. This is why the committee suggested the three priorities regarding temporary recommendation, that is integrated and reinforced surveillance, vaccination of high-risk groups, and continuing efforts for pandemic preparedness. I thank you for your attention.
Thank you very much, Professor Hussain. So I will now open the floor to questions. And the first question goes to Helen Branswell from STAT. Helen, please unmute yourself and ask your question.
Thanks very much. I was hoping we could get some more detail, please, about the Ebola outbreak in Uganda. In particular, in the cases in Kampala, there was a woman who gave birth. Were the health workers who attended that birth aware that she was, that probably infected with Ebola at the time of the birth, and were they able to take adequate precautions? Thank you.
Thank you, Helen. We'll start with Dr. Mohammed, and I suspect that Dr. Ryan may have something to add.
Thanks, Helen. As DG said, we have a number of recent cases that we are investigating, doing a detailed case investigation to understand how they are linked and the confirmation. As you may know, we had an initial case in Kampala that was also the health system have been on alert, and they have been prepared with fully aware about it, but the history of this case and the delivery was quite, a lot of information are coming up with the use of the PPE by the qualified. But as you know, the healthcare workers are quite large, so we are trying to understand more about the other healthcare workers. So far, 5 of them have been identified, and the government is looking into more details who are other people who may have come in contact on that. So we'll share as soon as we get more details. But just to point out the risk that's out there in Kampala, where a patient may be coming from a Bende and neighboring district without informing, or with coming with a different names and also present with a different systems. So we're aware, as DG said, we are looking into the detailed case investigation report and share with you in due course.
Thank you. Dr. Ryan does not have anything to add. So we'll go to the next question, which is from Sarah Newey from The Telegraph. Sarah, please unmute yourself and ask your question.
Hi there. Thanks for answering my question. First off, just on cholera vaccines, is this the first time guidance to do the one-dose approach has been issued? And secondly, just on some of the variants going around the world, XBB and BQ1.1 seem to be causing some concern at the moment. What do we know about them? And are reports that we'll see a swarm of variants this winter rather than individual ones becoming dominant there? Thank you.
Thank you. So that seems to be 2 questions. The first is on cholera. The second, you were referring to COVID-19 variants? Yes. Okay. Yeah. So the first one, we've got Philippe Barbosa online, and for the second, we'll answer that separately. Philippe, are you online? He's
Yes,
coming.
sorry. I got a very short cut on connection. Can you repeat the question, please?
Sarah, can you repeat your question about cholera? And Dr. Philippe Barbosa will answer that one.
Yeah, just a quick one. Has the guidance ever been issued to do the one-dose approach previously?
So thank you for your question. So the one-dose strategy has been proved to be efficient in previous outbreaks. There have been it has been implemented in different settings, and it has been assessed. So it is clear that the one-dose strategy is effective to control outbreak. The limitation of the one-dose strategy versus the second-dose strategy, it's the duration of the immunity it provides, and it also varies according to age group. So this is why WHO is recommending to have a two-dose strategy whenever it's possible to sustain a longer-term immunity, so for at least 3 years in the vaccinated population. Over.
Dr. Ryan will now answer the second question or the cholera?
Just continue on the first one. But I do think, and your question is well asked, I do think it reflects the scale of the crisis, that we are now in a situation where the ideal use of the vaccine is in a two-dose regime that gives people long-term protection. But the world is facing so many cholera events in so many places that the ICG is now forced to go back to a one-dose strategy, which in itself can be life-saving, but we're not sure about the length of protection. So that means we're adapting our strategies, not based on the vaccines themselves, but on the actual amount of vaccine available. Cholera vaccine, yellow fever vaccine, meningitis vaccine, Ebola vaccine are all maintained in global stockpiles between partner agencies, are made available free around the world on the basis of epidemiologic need. They're wonderful examples of how we can actually share equitably with the world. But because those stockpiles are of limited amounts, because it costs a lot of money to sustain them, and because these vaccines are not the ones that hundreds of millions of dollars are made on, it's difficult to maintain production. It's difficult to keep companies in production of these vaccines. They're not highly profitable. And it's a clear example when we talk about equity for the world. Now we're waking up to cholera as a problem because it's affecting country after country after country. The cholera pandemic never ended. The one that started in the 1960s, where Didier Hussein was talking about declaring the end of the fake. The cholera pandemic has been going for 50 years. 50 years. And we have the means to stop it. Two-dose OCV vaccine, safe water, safe sanitation. And again, the issue is we can't end the pandemic because we're not prepared collectively to put in place the basic human rights of water and sanitation and basic immunization in those areas at risk. And it's a sad day for us to have to go backwards to go to a one-dose strategy, which is life-saving. It's an emergency measure. We shouldn't have to do it. And it is purely based on the availability globally of vaccine. And we, again, would like to commend the manufacturer who stays in the manufacturing business. And that is a true partnership with the private sector. But it really shows how fragile global health security is when we're relying on individual manufacturers to continue to produce these vaccines. Thank you.
Thank you, Dr. Ryan. For the second part of your question, that should be Dr. Maria Van Kerkhove, but you may need to repeat your question, Sarah. Maria, did you hear Sarah's question?
I think I have it.
Okay, cool.
Yeah,
over to you.
I did hear it. Can you hear me okay? Okay. Yeah, so thanks. So I'll address the second question related to SARS-CoV-2 variants that are in circulation worldwide. So the question was specifically about XBB subvariant and BQ.1.1. But I do want to start out by saying that at the present time, there are more than 300 sublineages of Omicron that WHO and partners are tracking worldwide. Not one of these subvariants is dominant. I can say that most of the sequences that are available and that are shared with platforms like GISAID are the BA.5 subvariant and its sublineages. But this XBB is a recombinant of two BA.2 sublineages, and in particular BA.2.10.1 and BA.2.75. Now, we have approximately 827 sequences available to assess from 26 countries as of a couple of days ago. And we do know that this recombinant has a significant growth advantage. All of the subvariants of Omicron are showing increased transmissibility and properties of immune escape. With this XBB recombinant, we have one study that is based on a pseudovirus, so not a live virus, that is analyzing antibody escape, and it's showing significant immune evasion. And this is of concern for us because we need to ensure that the vaccines that are in use worldwide remain effective at preventing severe disease and death. And so the more this virus circulates, the more opportunities it has to change. The other subvariant that you mentioned, BQ1.1, is a subvariant of BA.5. Now this one, we have approximately 747 sequences available from 29 countries. Both of the subvariants that you mentioned, we don't see a change in severity, but it's very early and we have very limited data to actually assess this. What we need to do is put this in the broader picture. The emergency committee discussed this week and continue to recommend improved surveillance as WHO has worldwide. We need to be able to track this virus. There are millions of cases being reported each week, but our surveillance has declined, testing has declined, sequencing has declined, and that in turn has limited our ability as an organization with our expert networks around the world to assess these. The Technical Advisory Group for Virus Evolution will continue to discuss these subvariants, and in particular XBB recombinant that you mentioned, as well as many other sublineages that are circulating. But your question about will we see a large number of subvariants circulating in the coming months, that's happening now. So we need to be prepared for this. Countries need to be in a position to conduct surveillance, to deal with increases in cases, and perhaps deal with increases in hospitalizations. We don't see a change in severity yet, and our vaccines remain effective, but we have to remain vigilant.
Thank you very much, Dr. Maria van Kerkhoff. The next question will go to Brazil, to Isabella Abelen from Estado de Sao Paulo. Isabella, please unmute yourself and ask your question. Isabella, we're not hearing you. We're not sure, not online?
Alô?
Ah, there you are. Isabella, please go
Agora
ahead.
sim?
We can hear you, yes.
Ótimo, obrigada. Na minha pergunta, eu gostaria de escutar quais iniciativas a OMS está prevendo para melhorar e ampliar ações como a da Gavi para a distribuição equitativa de vacinas em caso de futuras pandemias. E se vocês pensam em vencer desafios como a concentração de laboratórios.
I got the question. So the question is, what is WHO planning to improve vaccine distribution? So I think we can either go to Dr. Bruce Aylward. We've got a number of people online to answer that one. Perhaps Dr. Bruce Aylward? Dr. Aylward, are you online?
Hi, Margaret. I'm online, but I couldn't hear the question clearly. So.
Okay. Would you mind, Isabella? The question I have is my question is WHO, what initiatives? And yes, repeat the question, and we'll all listen. So could you, is it about the distribution of the COVID vaccines or all vaccines?
Mary Angela can say what it was. Should I respond in Portuguese? No, I think... Obrigada, Isabela. Então, vamos começar pela primeira parte e espero que o meu amigo Bruce possa complementar. A primeira parte da sua pergunta, quais as iniciativas que a OMS está fazendo para garantir que estruturas como a Gavi sejam mantidas e que haja resposta adequada a pandemias. Isso é uma pergunta muito relevante e nós estamos baseados na boa experiência que nós tivemos com a COVAX Facility, no sentido de concentrar a compra de vacinas e de insumos relacionados à vacinação, concentrar numa estrutura global que facilitou que os países que não teriam condições de comprar individualmente pudessem comprar. Isso se dá, esses tipos de pool procurement, que a gente chama em inglês, que é de procura conjunta, ele se dá tanto através de mecanismos globais, como a Gavi e a Unicef, mas também, no caso das Américas, com o fundo rotatório da Organização Pan-Americana de Saúde. Então, há um esforço bastante grande em fortalecer essas estruturas que podem ajudar a prover vacinas para países que teriam dificuldade de acesso no caso de uma pandemia. Com relação à segunda parte da sua pergunta, a diversificação da produção, porque acho que essa é uma coisa extremamente importante, foi um problema verificado durante esta pandemia. Nós estamos verificando agora isso também com relação à cólera e a própria monkeypox, em termos de ter muito poucos produtores concentrando a produção de vacinas. E a OMS está, não apenas os Estados-membros aprovaram uma resolução para fortalecimento da produção local, mas também a OMS lançou iniciativas como, por exemplo, como se fala em português, o hub para a produção de vacinas com a tecnologia mRNA, né, que está localizado na África do Sul, mas do qual o Brasil faz parte, junto com outros 15 países, mas também uma estrutura, uma iniciativa global para melhorar a capacidade, para trabalhar com a mão de obra em saúde que trabalha no chão de fábrica, na biomanufatura de imunobiológicos, sejam eles vacinas ou, por exemplo, anticorpos monoclonais. Isso é uma iniciativa que foi lançada pelo Dr. Tedros. Tem um hub para essa iniciativa na Coreia, na República da Coreia, e a OMS trabalha com vários outros países nessa mesma iniciativa. Há uma necessidade muito percebida não só pelo setor público como o setor privado de fortalecimento da mão de obra que seja capacitada para trabalhar na área de produção de imunobiológicos. Eu vou parar por aqui e talvez meu amigo Bruce Hayward queira complementar.
Oh, sorry. Over to you, Dr. Hayward.
Yeah, thank you very much, Margaret, and apologies, Isabel, that we didn't capture your question correctly the first time. I'd like to break the response just into two pieces because it's an extremely important issue you raise right now, what we're doing to consolidate and enhance vaccination coverage, both as we get out of this pandemic, but also securing a future. Now, we're moving right now into a phase, as Maria and others have alluded to, of the pandemic, where many countries now are adapting their approach. And what we're trying to do through the ACT-Accelerator and the COVAX piece, if I speak first about the issue of COVID, is really three big things to enhance coverage as we go forward. One thing, we're continuing an R&D approach because we have not got optimized products yet that give really durable protection for long periods, easy to administer, easy to manage. So we've got to continue improving our products for the longer term. That'll help with demand. It'll help populations get the products they need. The second key thing that we're doing is that we're working with our institutions like Gavi that are part of the partnership, UNICEF, WHO, obviously, et cetera, to look at putting in place longer term, what we call institutional arrangements to make sure vulnerable low-income countries can access the vaccines that they need. We're also looking at expanding manufacturing, the hubs, the mRNA hub program that was alluded to, again, to ensure for the longer term now countries have access. And the third thing that we're doing is really helping focus our attention with countries to what we call our 100-170 approach, providing political, technical, financing and planning support to achieve, again, what we call 100-170, 100% coverage of healthcare workers, 100% coverage of vulnerable populations, older populations, on the march to 70% coverage in the countries. So we're really taking a three-pronged approach through this, what we're almost calling transition phase, as the world transitions into long-term COVID control, to help ensure that countries protect the populations they have to, have the best possible products, and have a secure supply for the long term through both international alliances like Gavi and expanded manufacturing. As we do that, Isabel, a crucial piece is we have got to do it in a way that's integrated with and supports work on routine immunization. Routine immunization underpins primary health care globally. And as we saw just about a couple of months ago, the Director General alerted the world to the alarm he had that we've seen the greatest decline in immunization coverage rates, routine coverage rates during the pandemic that we've seen in a generation. So on top of the COVID emergency, we have a routine immunization emergency. We've got to protect people against the measles, against polio, against all those other important diseases. So we have to do that in parallel. So sorry for the bit of a long-winded response, but the issue you raise is so crucial, right? This anchors our primary healthcare agenda globally. It's crucial that this and the COVID pieces move forward, and we've got a big agenda of work with, as you heard, clear priorities across both.
Thank you very much, Dr. Aylward and Dr. Shimao. The next question goes to Simon Ateba from Today News Africa. Simon, please unmute yourself and ask your question.
Thank you, Margaret, for taking my question. This is Simon Ateba with Today News Africa in Washington. On that shortage of cholera vaccine, I was going to ask, how did we get here? But it seems Dr. Mike Ryan has already answered it. It's the same story of great. However, how much do we need? How much money is needed to boost production to have enough vaccine globally? Also, I was wondering if you could comment on the announcement by President Putin a few hours ago that martial law will be introduced in 4 regions across eastern Ukraine. How does that affect the operation there? Are you even in eastern Ukraine right now? Thank you.
Thank you. Dr. Ryan will answer that question.
I can't give you an exact answer on what would it cost to boost production, Simon, but I can tell you if cholera was spreading in industrialized and wealthy countries right now, the production costs will be covered. Cholera vaccine is not a difficult vaccine to produce. It's actually a very cost-effective vaccine to produce. It's an oral formulation. It's very, very safe. And scaling up production would be relatively straightforward. Getting more manufacturers into production would be really helpful. In fact, we've seen manufacturers, and Mariangela said in her wonderful Portuguese, leaving the field of vaccine manufacturing. And in fact, this is the work that's being done now in COVID to broaden the base of vaccine manufacturing worldwide. I'll pass to Philippe. He may have some estimates on what it would cost to increase production. With regard to Ukraine, WHO is working in eastern and southern Ukraine. There's a very large health operation in the field with literally hundreds of health partners working with us and through the government. The issues for any health operation in any part of Ukraine or in areas occupied in Ukraine is access to health. Tedros has spoken about that with regard to Tigray. Most important thing we can do in any crisis is to get access to people so we can provide for their basic needs. So what I would say is no matter what law is in place, access to people who need health care is an absolute and fundamental human right and should not be affected by the imposition of laws that are security laws. Sometimes that's forgotten. And sometimes people's basic rights to healthcare access aren't compatible with some martial law arrangements. But it's extremely important that civilians, their human rights and access to healthcare are preserved, whatever legal processes are in place.
Thank you very much, Dr. Ryan. And Dr. Barbosa, do you want us to supplement? Go ahead, please.
Yes. So the exact amount of the thing which is important to understand is to start a new production of vaccine. It's not just it's a question of money, but not just that. It's to find a manufacturer that has a capacity that will build up on the production, etc. So for these figures of how much it will cost to invest in a manufacturer to develop a new plant, I don't have the answer. What I can tell you is the Global Task Force on Cholera Control has estimated last year that for the period 22 to 2025, the number of vaccines that could be needed is 250 million. So this is just an estimation, and that was made again last year. So of course, with the evolving epidemiological context and the increasing number of countries, including some that were not previously listed as endemic, these figures could change. But this is at least to give you a figure about the number of vaccines that could be required to appropriately respond to cholera, to outbreak, but not just to outbreak, also to be able to implement preventive vaccination campaign to prevent the outbreak from occurring. Over.
Thank you very much. Oh, and Dr. Sylvie Briand will add some points too.
Yes, for cholera, I think it's important also to understand that we know that on Earth we have hotspots for cholera, because cholera is due to Vibrio cholerae, which is a bacteria that is multiplicating in algae. And so there are some environmental components as well for cholera. With climate change and the warming of certain water places and deltas in the world, we see that the bacteria can multiply much faster. And this is why also we have much bigger outbreaks in certain places in the world. And I think this is why it's so important first to look at cholera as a global issue, because with climate change, we know that other places can become a sort of endemic places for cholera. And secondly, because it's very important to understand that if we can prevent outbreak in places where the cholera is in the environment, we will have a much better control on the risk. So preventive vaccination of cholera is of utmost importance, and those doses that are currently available, usually they are used to prevent outbreak in those places. And now, because we have outbreaks everywhere, we have also to use those doses for outbreak response. But everyone knows that prevention is better than cure. So I think the world needs to invest not only on the vaccines, but also on all the measures that can give to those populations safe water and sanitation, because this is where also we can reduce the risk.
Thank you very much, Doctors Briand, Barbosa, and Ryan. That was a really important question. I want to apologize to those looking at social media feed. I understand that the French translation's been coming in, and I do apologize for that. So we've now running short of time, but we've got time for one more question, and that goes to Lizzie Davies of The Guardian UK. Lizzie, please unmute yourself and ask your question.
Hi there, everyone. I had two questions, but I don't know if you've got time. Just a very quick one on cholera. Is this decision being taken with immediate effect? And how confident are you it will be reversed by next year? And on the Ebola outbreak in Uganda, the global stockpile for Ebola vaccines was set up in 2021, and I quote, to ensure outbreak response. There is now a new outbreak of a pre-existing strain, the Sudan strain, but there appears to be a serious shortage of vaccines to fight that particular strain. So who dropped the ball?
Thanks very much, Lizzie. We'll start with the first question. I think that Philippe Barbosa would be able to answer that one.
Yes. So this is an immediate decision. The country that were still expecting to have the second dose that was approved previously this year have been informed of the temporary suspension. The question about when will it be possible to resume the second dose strategy, because I think it's really important to insist that it's a temporary decision, a suspension, will depend on many factors. So it's not just about a question of doses. We know more or less how many vaccines will be available on the coming months. It's on average around between 2.5 and 3 million vaccines that are produced every year. But that will also be very much impacted by the dynamic of the outbreak and the fact that new country could be affected by outbreak. So it's impossible at this point of time to answer precisely when we will be able to resume and to make some prediction whether the situation will improve in the coming months or longer. The thing which is clear, it's ICG will revise this as much as information are coming in, both taking into consideration the vaccine production and availability, as well as the number of requests that are currently ongoing. So this is why it's important that beyond vaccine, and that has been mentioned a number of times, vaccine is a very efficient strategy for preventing outbreak. But it's only one of the strategies. And the thing that is very important to take into consideration is a very high case fatality rate, so mortality that we are observing in a number of places. And the ultimate priority is also to reduce and to put as much as possible effort in reducing this mortality. It's not acceptable in the 21st century that people are still dying in numbers of cholera. Well, it's a very, compared to many other diseases, it's a very easy to treat disease. The thing which really matter is the timeliness of accessibility to healthcare. So this is very important to consider that. And as it was just said by Sylvie, I mean, the point on improving accessibility to basic water and sanitation, healthcare setting, and improving surveillance. There are many other things that need to be continued in parallel. So the battle against cholera is not lost. We just need more support from everybody to contain the outbreak and over the time. So that over to you.
Thank you very much. And Dr. Ryan will answer the second question. Very important to clarify this issue.
Yeah, and possibly Anna Maria will just come in with some details after. Currently, the vaccine that was developed in West Africa and tested to the Sassofi trial and then further rolled out in Congo is a vaccine specifically designed against the strain of Ebola Zaire. And it has proven highly effective. And again, thanking the partners, both of the public and the private sector, who work so hard with WHO to bring that vaccine to the world, get that vaccine registered globally, and working with our colleagues in Gavi to stockpile that vaccine. And that vaccine has been used now in a number of outbreaks of Ebola Zaire since the major outbreaks in Congo. And again, those outbreaks have come under control in a very, very short period of time. Because the vaccine is available. And there is plenty of that vaccine available. The gap is that this is a Ebola virus with the Sudan strain of the Ebola virus, and these vaccines that were developed for West Africa and for Congo are not effective against that strain. That doesn't mean that no work has been done. Companies and public and private sector have been working very, very hard over the last few years. We currently have 3 candidate vaccines at least. There are others, but there are 2 vaccine candidates that are immediately potentially available. We're working with the Oxford Group in the UK, with SII in India, with the Sabin Vaccine Institute, with BARDA, with CEPI, and others to be able to bring those vaccines to the field as soon as possible. And there are other vaccine candidates further upstream, NIAVI vaccine and others. Ultimately, I presume our aim would be in the long term, if we can, is to introduce long-term protective vaccines that would be multivalent, that could protect against multiple strains. These are outbreak response vaccines at the moment. So the issue here is the fact that we have candidate vaccines available and that we can maybe hopefully get scaled up production of those vaccines, take those vaccines to the field and test them will be a very, very important innovation in the coming weeks and months. I think, I don't know if I fully got your question, but it's not that the current stockpile is not available, it's just that that stockpile vaccine is not effective against this particular strain. But we have solutions, and again, those solutions are coming through the system right now, with thanks to the partners in the UK and in the US who are working, and in India who are working so diligently with us to bring those solutions to the benefit of the people affected in Uganda right now. Anna Marie, if you're on, you might want to provide more details on the vaccine work.
Yes, I just want to add to what Dr. Ryan said, that we have candidate vaccines. It means that we have some preclinical data that suggests they may be effective. We have safety data and immunogenicity data that suggests that they may be efficacious, but we are running the trial with the government of Uganda and Makerere University precisely to document whether or not when they are given to people who are exposed to this Sudan Ebola virus, they are protected. That's first. Second, as Mike says, as Dr. Ryan says, we are working with partners, including CEPI and Gavi, to do two things. First, to ensure that we support the developers to have enough doses to conduct the trial and assess them. And second, in parallel and at the same time, to be sure that if they are successful in terms of efficacy, that we have enough doses to roll them out as experimental investigational vaccines like we did with DRC just before the Vivo vaccine got published and after we have the clinical efficacy data. And finally, with support with Gavi and other partners, we are looking on ways to ensure that any efficacious vaccines will be available in sufficient amounts. So this is not a question of supply and whether or not we have a stockpile. This is a question of a commitment from the government of Uganda with the researchers in Uganda to try to find another efficacious vaccine against another species of Ebola virus that causes death among their communities. Thank you.
Margaret, if I could just add, again, this work, and maybe one of the benefits we've seen over the last number of years with the work on the international coordinating mechanisms for cholera vaccine, for yellow fever, for meningitis, with the work on COVAX, the way in which the agencies now work together so efficiently, the work that we've been doing with Gavi and CEPI over the last number of weeks has been incredible. The work being done by the scientific institutions in the countries, the capacity in Uganda of their principal investigators and their scientists, and Makerere University at the Ministry of Health under the Minister of Health. So what we're seeing is a much more rapid capacity to bring science to bear in these situations, much more cohesion between the different agencies who can bring their comparative advantage. And lastly, I would thank the governments of the United Kingdom and of the United States, because without them working with academic institutions, without working with their own institutions, for example, HHS working with NIH and others, we wouldn't have these products, and we wouldn't have the facilitation that we have for these products to come to the field, the same with the UK government and the Oxford Group. So it takes a real partnership of government and the academic, the public and the private sector working together across countries with the multilateral agencies. And I would hope in this particular case we will get the opportunity to demonstrate yet another vaccine that may be useful in the fight against Ebola disease.
Thank you very much. And it's clear it's not a matter of dropping the ball. That was your question. It's a matter of picking up that ball as a team and really running with it. We have come to the end, and I'll now hand over to Dr. Tedros for his final remarks.
Thank you. Thank you, Margarita. And thank you to all members of the press for joining us today. And see you next time.
This show has been produced by Depictions Media. Please contact us at depictions.media for more information.